All right. Good evening, everyone, and welcome to the Together We Build Cancer Care virtual town hall. This is the sixth in a series of conversations looking at 11 program-specific areas of planning for the new Windsor-Essex Acute Care Hospital. Before we begin tonight, let's respectfully acknowledge that the Windsor Regional Hospital occupies the traditional, ancestral, and contemporary lands of the Niswi, Ishkoden, Anishinaabe, the Three Fires Confederacy, Ojibwe, Odawa, and Potawatomi. We acknowledge the land and the surrounding waters for sustaining us, and we are committed to protecting and restoring these lands and waters from environmental degradation. So on behalf of the project management team overseeing stage 2 planning for the new hospital, we're pleased to welcome everyone joining us tonight via Zoom webinar. I'm Allison Johnson, Manager of Communications and Community Engagement for the project, and your moderator for tonight's conversation. Tonight, you'll have the opportunity to meet some members of the user group designing the cancer center at the new hospital, to learn about the work that they're doing and to ask questions. So to ask questions, you will click the Q&A button at the bottom of your screen and type in your question. We'll do our best to answer as many questions as possible tonight. And at the end of tonight's presentation, if you still have further questions, we're going to give you a website where you can go and ask those. Now, please note the focus of this town hall is stage 2 planning of cancer services. And this includes items related to the physical structure of the cancer center, its layout, what other programs and services will be located nearby, design features, and technologies. To maintain the flow and focus of this conversation, please ensure your questions are related to these topics. And again, following tonight's conversation, we also invite you to visit our engagement platform at togetherwebuild.wrh.on.ca. Ask further questions, take our surveys, share your ideas. And now I want to introduce you to tonight's panelists. Please welcome Jonathan Foster, Vice President of Cancer Services, Dr. Sindhu Kanjakal, Chief of Oncology, Nicole Sproka, Director of Cancer Services, Lisa Favell, Consultant with Agnew Peckham Healthcare Planning, and she's been working closely with the user groups on the cancer team. Diane Marley is a patient representative. Dr. Andrew Petrakis, Director of Clinical Services Planning, and Paul Landry, Project Director for the new Windsor-Essex Acute Care Hospital project. We've got a great group tonight. Thank you all for joining us. So I want to start tonight with a question for Dr. Petrakis. Dr. Petrakis, we've talked about the many user groups that we have working on this. He is one of the links who sits on most, if not all, of these meetings. And Dr. Petrakis, when we're talking about the cancer center, the current cancer center has its own separate space in the hospital. How does the new cancer center fit into the big picture, and how will it be similar and or different from the new one?
Hey, thanks, Allison. I'd just like to say good evening to everyone. And as Allison said, she may have her outfit picked out, but I certainly won't have to change my hairstyle. On behalf of the 40 or so user groups, I'd like to thank all the community participants for being here this evening to share comments, suggestions, and questions regarding planning for cancer care. The Cancer Center services include chemo and radiotherapy, clinics, and is closely associated with inpatient cancer care. I just wanted to emphasize that as well, because this has a great emphasis on inpatient cancer care as well. The new cancer center will be designed as an integral part of the new hospital, retaining a separate entrance and parking with intuitive access to the main hospital building, services such as diagnostic imaging, pharmacy, and inpatient oncology unit. The center will be built to adapt to new technologies of the future. Thanks, Allison.
Thanks, Dr. Petrakis. Next question is for Jonathan Foster. What is the user group's vision for the new cancer center?
Thanks, Allison. And I'll echo Dr. Petrakis with just thanking everybody who has decided to watch tonight and participate. We're so excited about this functional planning group. The vision for the team and for all of us is to build a state-of-the-art cancer center that is for Windsor-Essex and our region. That includes all of the major components of kind of leading practice in cancer care. And Dr. Petrakis mentioned it will include radiation therapy, chemotherapy, and systemic suites, our clinics, but also our specialized treatment functions that we currently have and will continue to grow, cancer research and clinical trials. And part of this vision is to continue to move along that wave of development of cancer care and look to further expanding what services we can provide locally in Windsor, Essex. And a good example of that is planning to look at how we can try to deliver more stem cell therapies and transplant therapies closer to home and bring patients back to Windsor, Essex. We want to design this center. The vision is to have a center that is designed really with strong input from our patients, our families, and all of our stakeholders in the region. We know that we've learned a lot of really valuable lessons through COVID, but the most valuable lessons come from the experiences of our patients and our teams as we work through this process. And the last part of our vision is to really build a space that's going to stand the test of time, that will be able to sustain new growth, adapt to new technologies, and really be adaptable for things that we can't predict. And that's, again, another really good lesson that we have learned through the pandemic.
Thanks, Jonathan. And Jonathan talked there a bit about how this will impact parents, but Dr. Kandra, patients, not parents. I would like to get you to expand on that and talk about how will the decisions that you're making at these user group tables today affect patients who come into the new hospital and the cancer center there.
Great, thanks, Allison, and so happy to be here. You know, Jonathan was speaking about the larger vision, and being part of these user groups is really neat for me, because on the one hand, we have the big vision, and then on the other hand, in the user groups, we're really getting down to the nitty gritty about all the details that we have to think about to make the vision, you know, come true. And so, for example, when I think about it, I feel that we want to treat our patients in an environment that is as safe and effective as possible. And we want the experience to be efficient with the least frustration, and we want it to be warm and intimate and kind. And that's the kind of a feel that we want. And we're talking about very, you know, detailed conversations. For example, we're thinking about the chemotherapy suite. We need to design the chemo suite so it's larger. We need the capacity to expand in the future. And that's because we anticipate more survivors who are going to benefit from all the new therapies that are coming down the line. That's what the future is. We want to make sure there's privacy. We want to make sure there is space. We want community. All of those are things that we're thinking about for that part of, say, the cancer center. Another neat thing we're thinking about is bringing our interprofessional teams and specialists together. Right now, it's sort of all over the place, and the patient has to travel, you know, to each specialist, and they tell their story, you know, a dozen times, and, you know, it's inefficient. So we're thinking about centralizing, bringing the teams together, and then we go to the patient as a team, the specialists, the surgeons, the interprofessional teams like the social workers and the dietitians, all the people that you need to help you get better. So I think that is a neat thing. In that same area, we're going to have technology embedded in the clinics, because we need to look at the scans and we have to analyze the new molecular test results that are going to be spit out by the new molecular you know, labs that are going to be coming very soon. And maybe the patient will be sitting in the center of that team, and we'll be talking about these things together. We also need to think about space to recruit more doctors, because we need to bring the best and the brightest to our area. And we're doing that now with all kinds of great recruitment. We want researchers to be embedded with us, and that's happening through the University of Windsor and with Schulich. And we want to bring learners in, and that's happening now. We want to expand that. And we all need to be together to bring all of our energy and talent to the patient. In terms of infrastructure, you know, obviously we can't imagine what's coming. You know, 10 years ago, current immunotherapy hasn't even been invented yet. PET scan technology, the computer power needed to make that happen, it hasn't been invented. So we can't imagine what's going to be coming, but we have to have the infrastructure in place to bring those things in and be able to adapt quickly. And that's what the planning team is so focused on. Yeah, so I think that's the beauty of the working groups. Everyone's working, sharing, brainstorming together. And I'll say this again later, but we really do want to be a collaborative process where everyone has a voice, whether it's the folks working, whether it's the families, whether it's the patients. We want all of our voices at the table. So it's been a great experience so far.
Thanks, Dr. Kandra. And anyone who's been in the Cancer Center, well, ever, you know, it is a warm place. It is a nice atmosphere. And what I like when I am talking to you is you're always talking about what else we can make it, you know, not losing any of that, the warmth and the intimacy in there, but everything that you just mentioned that we have to look forward to, and that we're limited in the space that we have. Nicole, a question for you next. When you're at these user groups, what are some of the important considerations that the teams have top of mind when working on this project?
Thanks, Allison, and glad to be here with the rest of my peers and team tonight. You know, I guess I'm going to build off of what Dr. Kandra just talked through, because what she referenced in regards to the benefits for the future of the cancer program are also our influences and our considerations as we're talking this through. And really, it's multifactorial. So we're trying to be thoughtful and intentional around, again, in addition to what Dr. Kandra said, we're trying to consider accessibility, proximity to other resources. The cancer program needs every partner in the hospital. So adjacencies, accessibility, proximity is huge. Efficient flow, privacy. Certainly, I would be remiss in not mentioning equity and inclusivity. So these are all front of mind when we talk at our user groups. And certainly we talk around our model of care, our disease sites, our different needs of our different disease site teams. And, you know, just the last piece of it is very much the interprofessional nature of it. So including our frontline staff, our allied health, our providers. It's not limited to just administration. It's the voice of our patients, our caregivers, our family members, anyone who will need our support. So it's that diversity of voices, and it's making sure, you know, we have representation from a number of people that can really help inform what the build will look like. Does that answer the question, Allison?
Absolutely. Thanks, Nicole. So throughout this planning stage, the user groups are working closely with consultants from Agnew Peckham Healthcare Planning. And this team has been involved in planning many of the largest and most recent new hospital projects in Ontario and right across the country, including the new Ottawa Hospital and Humber River. And Lisa Favell from Agnew Peckham is now going to discuss the work that this group has done so far, and also some trends that her team is seeing in other new cancer center builds across the region.
Thanks, Allison. Again, like the rest of the panel, really excited to be here tonight. I think the piece that I love the most about the work we do is the ability to, you know, have that two-way conversation with all of the different stakeholders and people who have real valuable input to bring to the table, either based on their background as a patient or as a caregiver, or just because they're an interested party who just wants to understand more about a project. So happy to be here and share. So I'm going to share my screen because I have a bit of a slide deck. I'm going to try. So my slide deck tonight is short. Really what we're trying to do is just give you the sort of high level key elements of the pieces of planning that happen in stage 2A, which, as Paul said, is really the written document called a functional program that helps the design team and the users, including patients and family and staff, understand in a verbal fashion what the building needs to be. So there's the old adage that form follows function. We pair that need to understand what we're going to do in the building with an understanding of what's happened in the past in terms of changes in practice over time, which Dr. Kandra sort of touched on a bit in terms of, you know, when we opened the building almost 20 years ago, maybe over 20 years ago in Windsor, a lot of the things that are going on in it today weren't envisioned, couldn't be envisioned in terms of the provision of care that we provide to our patients in our community. So it's our job to try to take our experiences and our knowledge that we've learned from other projects and bring that to the table to a conversation with the user groups to try to inform a design that's written in a text format that envisions what the future is going to look like based on what we know today, but in a way that's adaptable and flexible so that whatever we see in the future, we're all able to accommodate it. So as you've heard, we're talking about the cancer services at the new hospital campus. And the major components associated with that at our user group tables do include the ambulatory clinics, radiation treatment, systemic therapy, administration. But we also want to make sure that we articulate for the user and for the design team in the future, what are the key things that are important to us about attributes in the hospital? Because we relate back to a lot of services, as Nicole said, that are located in the hospital that we rely on. Some of them more important than others, and we need to call that out. So we look at the flows in terms of how we're going to do our work, what volume or workload we're going to serve, and then what resources from a staffing perspective we require to accomplish that work. We want to be able to make sure that we understand what that looks like so we can articulate what we need to accomplish that work. Adjacencies are important and are described in the document, both adjacencies from an internal perspective. So for instance, we want to make sure that the specimen collection area that's taking samples for blood work is maybe adjacent to the front entrance, so it's convenient for patients. So we would want to describe that adjacency. But external adjacencies, like the relationship between the front entrance and the parking lot, are also key. So we list those kinds of adjacencies. And in discussing adjacencies, it actually forces us to think about how we do our jobs and the work we do and the way we do it. And so it's an important conversation that sort of threads through the entire development process of the functional program. Ultimately, the goal is to have detailed space lists that describe what we need in terms of rooms and the number and so on. But those space lists are a result or a final product from the conversations around how we're going to work, where we're going to work, and who we're going to work with. This functional program is describing 2 timeframes. So we're going to look at volumes and staffing for a decade from now and for 20 years from now. All of those pieces of the puzzle that make up the content of the functional program in stage 2B, as Paul described, will form the block schematics piece. So the bottom right-hand corner of your slide is showing what the end of stage 2B will look like. Blocks or chunks of space that are sized based on the space tables and put together like a pieces of a puzzle to meet all the adjacency requirements and descriptions we've provided in the functional program. I'll just stop and say too that it's a very iterative process. So we're very deliberate about having conversations, having a sort of a dialogue back and forth, really brainstorming and trying to be innovative and creative. I think as Dr. Kandra said, you know, it's a really exciting time and a very dynamic conversation that's happening around the table. So as we talk about what services we want to provide, I think one of the key things around that dynamic conversation is to really try to think outside of the box. So we have a way of working together today, but that doesn't mean that's how we want to work together in the future. We want to build on our successes, learn from other jurisdictions, other cancer centers, knowledge of other stakeholders who may have seen other models. And so we want to list those functions around the services that we're providing in an innovative way and in a new way of thinking about them. We then sort of translate that into the key operational processes that have to support those functions. So how are staff going to move through the space? Patients and families going to move through the space? And the materials we need to support that, how are they going to flow through the spaces? And this concept of really sort of the on-stage and off-stage environments kind of comes into play here, where we talk about, it's very important that patients can move through the building and have the processes surrounding them that they need to support them on their journey, versus just sort of this concept of making sure the building works. It's more than just making sure the building works. It's making sure patients are surrounded by the things they need to thrive. So how many patients? When will we expect to see them? What are our projections for visits and volumes that we need to support? And then what is the staffing and workspace that goes along with that workload? At the end, when Paul was talking earlier about the fact that we are going to write a specification for the building, the functional program will serve as a platform for that content. And we are very articulate and very deliberate about our adjacencies in terms of key departmental relationships, the organization of zones, the numbers of rooms required. So there is a lot of detail in the component and in the functional program, and that detail will carry through all the planning stages for the project. So it's almost like writing a prescription in a way. We're writing down for the users and for the design team and for the Ministry of Health and for cost estimators, what are the elements that we require to accomplish a finished building. Ultimately, that space allocation around the numbers of rooms and how big they will be will drive how big a building we end up requiring. So I just done some really quick slides here to sort of show some of the key concepts around new planning trends in cancer services. And one of the big things that's happened over the last, I'd say, 5 to 10 years is the way we organize our treatment areas. We're trying to be flexible and deliberate in the way we organize our space. So if you look at sort of this graphic on the slide here at the top, you'll see that each chair space or each stretcher space is the same size. So we're deliberate about organization of our treatment areas so that they can be switched in terms of functionality. We can turn areas on, we can turn areas off, and that allows us to have that ability to be flexible and adaptable. Another key piece around some of these things around trends in cancer is, and all of healthcare really, is this concept of operational efficiency. So making sure we really think about what's next to each other and how things are going to flow through the building. But ultimately, I think the biggest thing in terms of healthcare trends over the last decade or so would be the construct that we must be offering patient and family-centered care, and how the spaces we design have to support that. We want to look at things like, and we've been hearing this throughout our user group sessions, this construct of friendly environments, waiting spaces that allow you to plug in your computer, use your technology, find your way through the building, give you a variety of accesses to different types of spaces, making sure that we have amenities. One of the big things I think is this construct of clear wayfinding. I think the Windsor building does that very well now. That concept of find a window, you can find your way in the current cancer center needs to be carried through the new build as well. Making sure that people have access to views outside and green spaces where they can be quiet if they want to be and be alone and reflect. The concept of patient-led care is really growing, and this idea that patients want to be actively involved in their care plan. They want to navigate the services in a way that they understand and that they can access them. And so this is something that we're keeping in mind in all of our conversations at the user group table. Another, and I'm sure some of the other panelists will speak to this, but another key piece is this construct of wayfinding facilitation and having a mix of environments. Some people like to just be able to schedule their appointments on their phone through an app. And some people still want to have face-to-face time with a real person. And so we're having a lot of conversations about how we accomplish that for patients and families. So just a few examples of how we sort of want to organize the space. Dr. Kanjikal talked about the outpatient clinic setting where we would bring the services to the patient, wrap the services around the patients with central team areas surrounding examination rooms so that the team have the appropriate space to serve patients together as a team, rather than in separate little sort of office environment types of examination spaces. The decentralized construct of waiting so that patients can be closer to the space in which they're going to be cared for. Including psychosocial care front of the house. So psychosocial care will be integrated into the outpatient clinics, but it will also have its own zone to provide services to patients outside of that ambulatory outpatient clinic setting for when they need to return for other appointments. In terms of systemic therapy and pharmacy, a key adjacency that we've called out here, making sure that we have a mix of treatment environments. So some out, some stretchers, some chairs, certainly isolation rooms, really making sure that we can facilitate that face-to-face care with the nursing team and other staff who, again, will be serving the patient population. And then oncology pharmacy, making sure we have some safety with respect to how we move our drugs through the various spaces. And finally, the radiation treatment zone is really being divided into two kind of constructs, the planning piece of work and then the treatment delivery piece of work. And so we want to be able to make sure that we have a flexible enough environment to accommodate any kind of envisioned for the future technologies that we may see in imaging. And also on the treatment delivery side, we want to make sure that we have the ability to accommodate future technologies and make sure that, again, we're building an environment that supports the patients we serve. One of the new things I think that Windsor doesn't necessarily have today, but will have for the future, is an adjacent patient review nursing support zone. So adjacent to the radiation treatment units, patients while on treatment will have an area to go to have a nursing visit or a review visit with their oncologist. So this is, again, an environment that's coming out of the discussions from lessons learned from other centers and from just conversations with the radiation oncologists. So those were my slides, Allison. Happy to answer questions later on in the night if anyone has any, but just trying to give everybody an overview of the kind of content that's in the functional program.
Thank you so much, Lisa, for that presentation. And I want to remind everybody, please put your questions. We've got a few questions in the Q&A. We're going to get to those momentarily, but first, we do want to bring our patient representative into this conversation. Diane Marley, I saw you smiling throughout Lisa's presentation there. Diane is chair of the Cancer Program's Patient and Family Advisory Committee, and she sits on several of the user groups designing the new cancer center. So Diane, I want to ask you as a patient, obviously bringing a very important perspective into this conversation, what considerations do you find most important in these conversations and why?
Thanks, Allison, and I'm so happy to be here. I'm just going to start by saying all those years ago that I sat through all those presentations that went to all of those centers all over Windsor and Essex, listening to what we were hoping was going to be our big project, and now we're here. So it almost feels like a very surreal moment in time. And I got to say, I find it a very huge pleasure to be part of this group and this new build. It is so exciting. To answer your question, I feel like, you know what you know. So we know the cancer center that we have now. We know what we love about it, and we do love our cancer center. So I think as a patient representative, I have to make sure that I break my mind from that to say, oh, I just want this one over there, because that's not what we're doing. We want the real highlights of the cancer center we have now, and then all those sort of wish things that right now we could say, we kind of wish this is happening, or we kind of wish that was in our facility now. And I think the biggest thing that I get from it, and I know Dr. Kanjikel has already mentioned it, and it's been mentioned a few times, Nicole as well, is that warmth and that the way our cancer center feels like a clinic It feels like a warm place to come to get treatment for a disease. And we feel like, yes, we can conquer this thing. And it really has an awful lot, and it really does have an awful lot to do with the building and the way it happens, and all that natural light we have and all that beautiful wood we have right now. And I think a lot of that we've already been talking about is going to carry over, and all these wonderful things will carry over. And not only will that be, but we'll make it even better. And that is so exciting, because even the smallest things, and we were talking and I brought it up and Lisa said, no, you should talk about it, but it's the number of washrooms, the number of places to get something to drink. And is there going to be something comfortable for the caregiver who right now sometimes is just sitting on like a little task chair all day long, my poor sister, because of the way things went with me. So it's those kinds of things that I'm hoping to bring to the table, and we just bring that user feeling because we were there, we experienced it, and we're ready. We're just ready for the new facility.
Yes, I think I'll second that. We are ready for the new facility. And just very quickly, how are you finding this process of, you were one of the biggest cheerleaders for this project, and sat through very many town halls going through in stage 1. How are you finding the information that's being shared at these tables and the process?
You know, it's very interesting because I could never have envisioned that this is how this works. Sometimes you just kind of think, well, they've just built another hospital in another city. Can we just not, why don't we just do that one here? Well, that's not how it works, right? We have an opportunity to say, boy, we wish we had, and then X, Y, and Z. And it is very interesting. It's very inclusive. You know, you set a time period for your meeting, but it can, sometimes it's going to go over a little because we have a little bit more to talk about. It's very open. It's very, like I say, very inclusive and detailed. It's far more detailed than I actually thought we'd be at this stage. So very interesting. I'm looking forward to every stage that's coming. Because it is just going to be exciting.
Especially stage 5, the end of stage 5.
Especially, yes. I hope I haven't exactly picked out my outfit. I'm just hoping to still be here. I'm a lot older than you.
Thanks, Diane, for that. And I do want to remind everybody, please put your questions in the Q&A. We're going to get to those in just a minute. To build off of what Diane said, though, I do want to ask Jonathan before we move on, why is it important to have the patient perspective? That may be obvious, but what are we hoping to learn from patients through this? It's important to have patient representatives at the table, but also so important that we hear from everybody who's joining us tonight and everybody who will watch this in the future and find our website and provide comments there.
Thanks, Allison. I was just going to say that listening to Diane speak really says everything you need to know about why it's important to have our patients and families at the table. So we're really lucky to have Diane both as our PFAC chair and as participating in the planning process. And in addition to that, we've got a number of our PFAC members taking part in various streams. But beyond our PFAC, which is a good volunteer organization, we do want to hear from everybody. And we want to hear every type of suggestion, idea, even questions that trigger us to think about things in a different way. I think the value of hearing from patients and families is it keeps us real, so to speak, as a planning team and as an administrative and clinical team. And it always grounds us back to the fact that we're doing all of this first and foremost for our patients. And so I think that the vision really is to have, by this consultation product, a cancer center that's shaped by the people of Windsor-Essex for Windsor-Essex. And I've said this in other streams, but it's so important here in the cancer one. The best outcome would be somebody to walk into our new cancer center and encounter an aspect of that center or feel something in that center and be able to look at it and say, that was my idea. I suggested that, and here it is. So that's why it's so important.
Thanks, Jonathan. And we've talked about the site where we're capturing all your ideas. If you go there, it's kind of fun. You can post your ideas as like a sticky note, and then people can comment on them. They can like them. They can further that discussion. We do, throughout this conversation and throughout all of the conversations over the past week, people are also sharing their thoughts here. And I encourage you, Jennifer has put in the chat section our website. Please go share them there as well. We will capture everything that's here and make sure that it's all included at the end when we share all of the thoughts with the user groups, but please check out the website. And I do want to start out, I don't normally mention some of the comments that are made here or the ideas that are shared in this forum, but I want to thank Ashley. She's provided a couple so far, and we will make sure that those are included. Ashley says she was a childhood cancer. She was in the hospital with childhood cancer, and she's suggesting different sleeping options so that parents can stay closer and stay comfortable. So thank you for that. Moving on to the questions, I'm going to start with a question for Jonathan. And the question is from Raymond, who wants to know, can startups use the LINAC equipment for research and development?
Thanks, Raymond, for the question. And I saw that on our website as well. It gave me time to prepare for to answer you. And I want to start by saying that we're very supportive of startups, especially startups in research and development. The key issue with our LINAC machines, and for those of you who haven't heard the term LINAC before, those are the machines that deliver the radiation therapy for our cancer patients, is that they're highly regulated through both federal and provincial guidelines. And that really drives who's allowed to handle and operate the machines and for what purposes. So the sad answer to that is, unfortunately, no, we wouldn't. But I will follow up by just stating that we do, as a cancer center, participate through Ontario Health Cancer Care Ontario. So OHCCO is the new CCO. A lot of cutting edge research takes place throughout the province in radiation, and with, in particular, using the LINACs, and that technology continues to evolve. So if there ever is a question specifically about that, please reach out to either myself or anybody in the center, and we can direct you to the best experts to answer those types of questions for you. And I can answer the follow-up question at the same time, which is also from Raymond, just in terms of whether proton therapy equipment will be there. And at this point in time, proton therapy isn't part of the plan. But as I stated earlier, we're designing a center that's going to be very nimble and responsive to evolutions in technology. So right now, my understanding is that that type of therapy isn't being delivered in Ontario. And Dr. Cangicle or Nicole can correct me on that. I see them nodding, so I'm right. But again, we know that technology is advancing at a pace faster than we can truly keep up with. So in our future state, we hope to be able to be responsive enough to, if that is the standard of care, that we'll be able to provide that.
Thanks, Jonathan. A question for Lisa. This one's from Jeff, who wants to know, from a patient perspective, how will the look, color, light, sound, and smell be taken into consideration in the new hospital?
Thanks. Yes, absolutely. So there is usually a whole specification, and Paul could maybe elaborate on this, but specifications will articulate some of those considerations in terms of environmental considerations, but also picking up on, some of the comments about how great the current building is in terms of its aesthetic. One of the key pieces that we'll articulate throughout the process will be making sure that the fit and finish and environment that we provide for our patients and our staff is one that's conducive to, environments that support care, environments that support the work in an efficient way, making sure that, there are considerations with respect to making sure there aren't smells wafting through the HVAC and those kinds of, negative effects on the environment. But there are entire specifications that deal with just those issues, and consultants whose job it is to make sure that, the type of carpet you're picking is visually and aesthetically pleasing to patients and to staff, making sure that you're not creating colors or feelings in the building that can be antagonistic, for instance. And for anyone who's spent any time in the design world, it is really quite a fascinating discipline in terms of looking at the impact of color and the impact of smells and finishes on productivity, on feelings and comfort. So yes, absolutely.
Thanks, Lisa. And Lucy Brune, who's also from Agnew Peckham, who we've spoken with several times here as well. She often says when we talk about things like lighting and color, she says, you're going to love stage 3. And I think that we are all going to love stage 3 when we start to get into the more finer details and what it will be like in the hospital. But I do want everyone to know that all of the feedback that you provide here will be summarized and prepared in a report that we will share with people who come on board through this project throughout the process of building, and we can continue to add to it and develop it as well. Paul, I see that you had your hand up there. Did you want to add to that?
Yeah, I was just going to add to what Lisa shared with us there in terms of these types of details are awaiting us in stage 3 and also in stage 4. But also to echo what Diane shared with us, we really want to keep all of the best ideas of what we've already got in a great cancer center. And we want to expand upon that and make it even better in the future cancer center. So our patients have embarked on this journey with us, and they're here at this functional programming work where we're having lots of discussions about lots of details and lots of clinical issues and patient experience issues and patient and family issues. And their participation in that is critical. But they're also going to enjoy, as I mentioned to them at the kickoff meeting with all of our patient representatives, they're going to have a lot of fun with us as we go through these various stages together. And as Lisa pointed out, there's really a whole science behind color selection. But aside from the science, we're going to have our patients at the table as well when we make those choices of what the look and feel of the future cancer center will be like. So it's a long journey, Diane, and we'll be getting into those detailed discussions in stages 3 and 4.
Thanks, Paul. A question here that actually has been answered by Dr. Petrakis in the text, but I want to ask it so that other people might be able to hear the answer if they don't have access to the text as well. This one's from Ashley, and she wants to know, she says, cancer patients usually have a need for a private room during their hospital stay. Will there be a wing dedicated to cancer inpatients and where there will be private rooms?
Yes, I did hear you, Allison. My power is back on again. It must have gone off about 6 times in the past 20 minutes. But to answer the question, thanks for the question. All the private rooms in the new facility are being designed, or all the rooms in the new facility will be designed as private rooms. The association of the cancer area will be in close approximation to the cancer center itself to provide convenience for both patients and for staff going back and forth. As well, there'll be adjacencies to the necessary services, diagnostic imaging, the operating room, emergency department, and the main corridor of the hospital or Main Street to have easy access for patients and families to get to the cancer wing.
Thanks, Dr. Petrakis. And I do want to invite everybody who is interested in that to join us tomorrow when we're talking about the planning of inpatient units in the new hospital, where we'll learn a bit more about what the rooms will look like and how they'll be spaced out in the new hospital. Question now from Charlotte. Jonathan, I'll ask this one of you. Will the cancer center be open 7 days a week and holidays?
Currently, things like our staffing model, hours of operation, when things will be delivered, it's still under review. So we don't have a definitive answer for that yet. We know that in our current state, we're working through weekdays and not on weekends because it's an outpatient ambulatory service right now. But again, these are all things that we've got to look at as we move along. And I will say on that one, the patient voice and the family voice will be a big weight in those conversations for us, a big factor that we've got to take into consideration as well.
Thanks, Jonathan. We have a few more questions here, but I will encourage anybody who wants or who has a question that they're sitting on, please put it in the Q&A section now so we don't miss anyone's questions tonight. A question from Jeff. He wants to know about the caregiver experience, which he said is paramount. And what considerations will we have in the new hospital for that, Jonathan?
Yeah, I was actually thinking it could maybe tackle both of Jeff's questions there together. Jeff, really great questions tonight, so thanks for that. And you hit the nail on the head, and Diane talked about that herself, that the caregiver experience in cancer is really part of the patient journey. So caregivers are part and parcel of that. We have to factor that in. One of the things that we're dealing with in our current space too, compounding, maybe not having enough design for that, is that we've outgrown our space. We're spilling into all areas. So spaces that might have once been able to accommodate that more comfortably have become less available and more crowded. And so at the beginning, when we talked about having a space that's flexible, somebody used the term accordion once, and I thought that was really a neat way to describe it. So a space that can expand and contract as we need it, while maintaining those standards of comfort for patients and for caregivers, is really key and has been a big part of both what Diane and the patient representatives in our user groups have been talking about, and also the feedback that we've been getting overall. And one of the notes that I made just in listening to your questions was how care is delivered and the environment that it is delivered in has a great big impact on patient outcome. We know this from all kinds of research. So definitely those are things that we have to continue to put voice to. And we keep talking about the exciting part of stage 3 when we get to look at pictures, but this is the really important part where we're going to put in, this is like a recipe. We're giving the ingredients, and we're going to have some great artist chef come along and prepare us in something magnificent based on all of that. So this is why this journey really is so exciting for us. And to your second question about it being overwhelming, I was really worried walking into this process, and I think several of us on the team were, that it would be an overwhelming undertaking. But because it's been so step by step and planned out so well, it's been easy for us to work through as a team. And again, getting everybody's input, it's not one person that's making key decisions. It's done as a group, as a collective, and really with the community. But some of the key lessons, what was your question was, is we do know through COVID that we have to have spaces that are going to be able to adapt for the unforeseen. We would never have anticipated that we would have to have spaces that used to be wide open that now have to be safe from an infectious control perspective. How do we accommodate that? So lessons learned there. Lessons learned in terms of if we build something that's really critical infrastructure, like our radiation machines, in a space that can't be expanded outwards, we're really kind of shooting ourselves in the foot because we can't work through that. So we've decided that we have to have, and we're going to challenge the design team to say, show us scenario A, B, and C if we had to expand through contingencies 1, 2, and 3, so that we know it will work. It's not just we hope it will work, but we know that we've got a plan for that. So those have been, for me, some of the biggest lessons. But I don't know, Dr. Kanjical or Nicole or Diane, if you have anything else you want to add there.
Thanks, Jonathan. I was going to, I think Jeff makes a really good point about how we have, I think, historically overlooked the caregiver. I imagine that if I was sick, I would care so much about the people in my family and the people that are helping me. And if they're having a difficult time to find a place to sit or to rest or to do their work that they're missing, that would impact me as the patient. And I think that we have overlooked that, and we're talking about that very actively in these meetings. So I just wanted to highlight that point. I think it's a good one.
I would agree with both Jonathan and Dr. Kanjical too. And I really do feel like that is my role, because we lived it. And whereas of course we know that the clinical space and what happens when you're there is of course paramount. That's why you're there, is for your treatment. It's to get better. But also along the way, there are those times where you can say, this could be better, or this could be different to make it more comfortable, or we never thought of that maybe before. that whereas I was supposed to be in there for a 3-hour treatment and it turned into 12 hours. And so where is my caregiver? Where was my sister sitting? Well, she had to move because of other equipment came in. So now she's on the other side of me. And then she had to change chairs because that one couldn't fit. And then, so it's all those little things. And Jeff, to your point, that's going to be my job. I am going to remember all those things. And I'm going to jump in there and say, please don't forget this, because this is critical to what happens. Because like Dr. Kanjikal just said, this is your loved one that you are clutching onto for dear life while you're having your treatments, and you don't want to see them, you know, be uncomfortable for all those hours sitting there. You want to know that they're doing okay too, because they're there for you. So all those things though, and I'm going to rest people's minds that are listening, we are discussing, and we're going to make it work, and we're going to find the best solution to all of those things, because yes, we're talking about it.
Nicole, before we move on, did you have anything to add?
No, I can't top what those, you know, my teammates here alluded to. Those are all critically important points, great questions, and we're on it. Thank you, Diane, Dr. Kanjikal, and Jonathan for that. So,
thank you. A question and a comment from Sarah. Sarah said, I would have been interested in taking part in patient consultation groups. And Sarah, we wish that we could have every single one of you here with us tonight and out in the community on these groups, but that's just not possible. Some hospitals at this stage don't have the patients at the table, but for Windsor Regional Hospital, that was very important to us. And in order to do that, for this stage, we did look for patients who are already involved. As we mentioned, Diane is on the PFAC committee and already understood the hospital. But again, we want to hear from every single person out there throughout this project and throughout the entire process. So it's very important that you're here with us tonight, very important that you're sharing, and please visit our website and continue to do that so that we do capture all of the different experiences out there and how we can build a hospital to suit all of them. Additionally, Sarah said there are many small details, especially for those of us who don't have family accompanying us, such as lockers for coats, even for the chemo suite, and facilitating movement through the center when you're on your own. Jonathan, how is that covered in this planning?
I might start this off and then kick this off to a couple team members, but I just wanted to say to Sarah, this is a really great example of why having this type of question and answer is so helpful. We've talked about lockers for our staff a lot, but I don't think we've really thought a lot about storage for patient belongings and things like that in the cancer center. I know I have in other streams. So thanks for raising that. I think it's definitely something that we can take back for discussion. But I think Lisa may be the best person to talk about, finding your way through the center, especially when you're on your own, because she's got a lot of experience and knowledge there and ideas for us.
Thanks, Jonathan. So I think one of the best things, and I think to some degree Windsor does that well, is letting the building drive the wayfinding. So challenging the design team to ensure that, whether it's keeping windows along corridors or making sure that there's sort of visual cues. So for instance, in Grand River Cancer Center, at every main thoroughfare or a point that you need to remember to find your way back to your car, there's a quilt. Because the Mennonite community is so large in that particular region, they decided on using quilts to help guide wayfinding. So there will be conscious conversations as you move through the design process around how to improve wayfinding with your design team. I was here and now I need to get here. How do I do that in a way that's convenient, but also obvious? There's nothing more stressful, I think, for patients and their families to feel like they're lost or being late for an appointment, or that they're going to miss something that they're supposed to be at. So the building itself, I think, needs to provide that intuitive wayfinding piece. And then I think it's also important that there be people stops along the way, if that's the right kind of terminology, that there still be a reception station or some place where we had talked about in some of the user groups meetings, this concept of a concierge, a person whose job, a volunteer whose job it is just to help people with wayfinding. You know, I talked a bit in my presentation about the variance of patients. Some are very self-reliant and just want to march along on their own time, while others want to be helped. They want that contact with a person. So I thought that was an innovative approach that was raised in a couple of our user group meetings, was this construct of having literally someone help you along the way in terms of a concierge kind of activity. So I think it's having a variety of options to help with that wayfinding, but first and foremost, familiarity and make the building help you find your way.
Thanks, Lisa. What a great opportunity to have the opportunity to consider all of these things at the same time while working toward a new facility. Question from Janine. I'm going to address this one to Paul. Janine wants to know what considerations are being made for air purification within the new cancer center.
Thank you for your question, Janine. And we had a very interesting conversation last evening in the town hall for surgical services. And we were posed a very similar question about, air filtration, especially in the ORs. And our response was that, engineering and design has evolved so much in recent decades. We're now talking about 15 to 20 100% air exchanges per hour in an operating room. And of course, that air is completely HEPA filtered, so it's very pure air that's going into the OR. And that doesn't surprise many people when they hear of that. But what's maybe a little more surprising is that in the whole rest of the hospital, inpatient rooms, offices, cafeteria, main lobby, all of the rest of it, we're looking at approximately 6 100% fresh air exchanges per hour. So every 10 minutes is 100% evacuation of the air in that space and filled with new air that is filtered as well. So when we talk about, the impact of oxygen and of having fresh air, we indeed, from an engineering perspective, will have that throughout the hospital. There was a similar comment about food and food that's coming onto the floor. And while we don't have the kinds of ventilation systems in our existing older facilities that we will have in the new one, but I think that this concept or this technology of evacuating the air that many times in an hour will deal with part of that issue of smells of all kinds of types in different areas of the hospital.
Thanks, Paul. Another question from Ashley. She says, during my time in the hospital, I enjoyed having a bath to de-stress and feel a little more normal. There was only one bathroom that was available when I had my treatment years back. More comfort options with baths would be a great idea. Lisa, is that something that is being considered in this? And I'm not sure if she's talking about inpatient rooms here.
Mm-hmm. I think so.
Yeah.
Yeah. I think she's talking about inpatient rooms, and I'm not the planner that's looking after the inpatient unit, but maybe Paul or Dr. Petrakis, you could comment on it. I'm assuming that there will be with private rooms in each of the inpatient modeling. There would be access to a dedicated washroom for each inpatient bedroom.
Sure, I can add to that, Lisa. The inpatient units town hall meeting, I believe Allison is coming up. Is it on Thursday evening this week? Just to reassure you, Ashley, was that Ashley that posed that question? Yes. At a minimum, we will have a room on each inpatient unit with, I will say, a bathtub, but it may be actually more than one type of bathtub. for bathing purposes. But your suggestion is a very good one, and certainly when we look at the various facilities that make up an inpatient unit, we'll certainly be discussing that one in detail in terms of how many types of rooms might we need on an inpatient unit. As Dr. Petrakis confirmed in one of the questions that we received, we are planning, in keeping with the new hospitals that are being planned and developed in recent years, that the new hospital would have 100% single rooms. And within those single rooms is a 3-piece washroom that includes a shower in it. And I mean a shower that is totally accessible with no lip that a person could trip on entering the shower, and actually a shower that is large enough even to shower someone, in a wheelchair. So a lot of those details will come later when we're actually planning the inpatient rooms themselves. But thank you for that suggestion of having a bathing room on the inpatient units.
Yes, and please join us tomorrow. Tomorrow's the inpatient unit conversation, and I'm really looking forward to that one, because I think that that's where there's the most visible difference, or people who spend time within the hospital, you'll note a difference between the current inpatient experience and what they'll be talking about tomorrow for the future. And another question here from Ashley, who says she doesn't have much experience in the cancer clinics, but she suffers from anxiety and was wondering if it might be a good idea for patients to be able to mark their mood that day, such as a talking mood or a not talking mood. And Jonathan, you maybe can take that.
Yeah, a couple thoughts, Ashley, in response to your question. So let's see if I can walk through them in an organized way. So number one, thanks for talking about your anxiety. It's incredibly normal, first of all, for any of us to have anxiety under current circumstances. But second of all, going through a cancer care journey, we know that anxiety is really a product of, or it goes along with many of the conditions and the treatments, and it's really natural. And I think it's empowering to talk about it. So thank you for that. Part two is we are starting to pay, and this is less about our design and more about our programming, but part three will talk about design. So in part two, we're looking more and more about those, what we call psychosocial oncology pieces. So patients' emotional, behavioral health. We know that cancer care is holistic in nature. So one of the things that we're going to be getting back to doing is doing more work on screening how people's symptoms are, how their overall wellness is. We've got a few standard ways we do that now, but it's ever evolving. And I think your point is good, that we have to factor that in when we're talking to people, because it influences how people are able to communicate with us and how they receive information. And then part three is, that's the real beauty of a great design opportunity like this, is that we know, and I said it before, the environment that you receive care in has a big impact on the outcome that you have. So understanding that we are going to have patients that might be having anxiety, other mental health conditions, independent of their cancer journey or in relation to their cancer journey. How can we use technology to eliminate some of those barriers that somebody might have, where we can use pre-registration, pre-check-in, simplify the journey, front load information so that anxiety and ambiguity is kept to a minimum, being able to find your place and your way, and not having to move a lot through the center, as Lisa talked about, having things to come to you, are all things I think that are going to be really conducive to helping to support individuals who might, like you, be struggling with anxiety. I hope that answers your question in the way that you were looking for.
Thanks, Jonathan. And thanks, Ashley. And thanks everyone who continues to provide different suggestions for this. And one more time, at the risk of sounding like a broken record, please visit our website, and so that we can capture all of these ideas and we can share them with the planning teams moving forward. Last question.
I was going to just add one more thing to Jonathan's point. I just wanted to share that there is this, evolving appreciation and understanding about the role of psychosocial importance in oncology. And so Cancer Care Ontario is, I think, finally putting some effort and real resources behind that. And the psychosocial oncology team that we have at the Cancer Center is also, I think, weighing in on what we can do to make the experience better from, you know, a really objective and research-based way.
Thanks, Dr. Kanjiko. Last question of the night. And once again, anybody who didn't get their questions in, I think we got to all of them that I see here, but please visit our website and share any questions that you think of after this. Last question, we'll start with Jonathan. I've heard research mentioned several times now. Great to hear. How is that being integrated?
Yeah, so I'll start it out and then maybe get others to chime in. Research, and in particular clinical trials, is a real staple of cancer care. And we currently participate in a lot of funded cancer research, and especially, like I say, clinical trials. As I mentioned before, we're really spilling through our own space now. So as we move forward in the design process, working with Lisa and the team, we're going to have to factor in the space that our clinicians will need. And when I talk about research, it's research that directly touches patients and provides them access to the latest and greatest innovations in cancer care. And so I don't know, Dr. Kanjiko or Nicole, if you want to add to that this will continue to be a focus for growth for us. And it's one of the few aspects of healthcare where research really is embedded within the operations of the center.
I'm happy to jump in just to augment Jonathan's comments, if that's okay. My internet says it's unstable sometimes, so apologies if I freeze up here. But I think what I would add is that not only, Jeff, to your question, is research and clinical trials a focus within the functional programming for the cancer program. It's its own standalone entity for the hospital as well. So there is the education research streams that are happening, and I think it's going to be bi-directional in the way it's going to be planned, certainly in the way of expansion, innovation, building upon the strong foundation we already have within our cancer program in the clinical trials. So where we can move to in the way of, you know, phase 1, 2, 3 trials, certainly broadening our base, lots of opportunity to grow. So maybe I'll pause there and see if Dr. Kanjiko or Dr. Petrakis have anything further to add.
Yeah, I think I can just echo what's been said already, and just say that clinical trials research is fundamental to excellent cancer care. We have to have that, and we have to have space for it to grow, both in the systemic and in the radiation and in the palliative fields. And I think we will partner with lots of other departments in the hospital too that are going to build research programs and platforms, for example, with radiology, with surgery, and so on. So that's absolutely fundamental. And then, as many of you know, we've also been really actively building relationships with the University of Windsor and with Schulich to bring researchers, basic science researchers, epidemiologists, nursing, medical school, all of the research being done in academia to come to bear on our clinical work. They have to go hand in hand, and that's the future, and we know that, so we have to make it happen.
And just to add a bit to that, the Windsor Cancer Center has always been leaders in research. Even from the time that I started practice back in the early 80s, they were leaders in research, and they continue to be so. They've formed linkages to the research department now and to the university. And I think this is only promising for our entire future here in Windsor and the new hospital.
Thanks, Dr. Petrakis. Anybody else want to add? And actually, I should check in now with all of our panelists and see, is there anything that we haven't covered? Great discussion today. Does anybody want to add anything before we say goodnight? Seeing none. Paul, you look like you're about to say something.
Sure, maybe just a quick comment. I wanted to pick up on something that Dr. Kanjiko had shared in her initial comments about, forecasting or looking ahead at emerging technologies that are just changing so rapidly, and the work that we're doing today, in developing a functional program and then moving that into, a design process for things that are surely going to change, in the coming years, and in healthcare, in hospitals, and in cancer centers in particular, things change rapidly. Technology changes rapidly. And she mentioned flexibility. And I just wanted to assure the audience that, and I think Jonathan touched on this as well, when the architects are onboarded with us, we truly will be challenging them to develop a building and a building structure. If you could consider the shell, and if you can consider the columns and the grid, to really develop a building that has maximum flexibility for us to make changes inside the building and also to add on to buildings. There are particular areas that are very challenging, like the cancer center, where we need to be able to have that kind of flexibility and growth path, for the future. And other departments, would include the emergency department, the OR block, diagnostic imaging, as three other particular departments where we have to really have a shell that is flexible so that we can grow into the future. So I really appreciated her comments on, that concept of flexibility and how do we, challenge our architects to come up with a building that will respond to the changes that are coming in the future.
Great. Thanks very much. Thank you to everybody who joined us tonight, all of you who tuned in, all of our panelists. Once again, we invite you to visit our engagement website. Bear with me one more time, togetherwebuild.wrh.on.ca. If you haven't checked it out, please do. Continue the conversation, post any ideas that you haven't shared tonight for the new Cancer Center, take the survey, and this site will remain active for about a month after this conversation, so you can continue to share your thoughts. And then following that, the results will be summarized and shared with our planning teams. So your input, again, will help guide the decision-making throughout the project. Please take the time to visit the site. And then later this year, as Paul mentioned off the top, we're going to do this all again. You'll have a chance to see how the planning has progressed and how this input was used in the planning. I want to thank you again for taking the time to be with us tonight, embarking on this journey with us as we plan the future hospital. Really, truly is a once-in-a-lifetime opportunity. I hope you'll join us again tomorrow, same time, same place. Tomorrow, we're looking at the future of inpatient units. And huge thanks to all of our panelists for your time this evening, all the work that you're doing in the user groups, all the work that you're doing in the hospital, in the cancer program. And for the final word tonight, I would like to turn things over to Dr. Kanjikal.
Great. Well, this hour and a half flew by, and I've learned so much just in this little bit of time together. And I've learned so much, and I continue to learn as the process goes. So thanks for joining us tonight. I hope everyone feels the sort of the sense of anticipation and promise that I think we all on the working groups feel. And every idea is valuable. Every idea is something that none of us here will think of. So we would love to have your voices, and really appreciate the team around us.
Thanks, Dr. Kanjikal. Thanks, everybody. Have a good evening.
Thanks, everyone. Good night.
Thanks,
Thank you.
everyone. It was a lot of fun. Thank you.
Thank you. Good night, everybody.
Night.